Thank you, Mike. There are question cards. If you have some questions, write them down, and if we have time, we'll get to them at the end. I'm going to talk to you about class 3 mutations, and we're going to start by looking at another video. These are learning objectives for the talk about class 3 mutations, potential therapies for class 3 mutations, and the mechanisms. So go ahead and put your glasses on. We're going to see Dante and hear about his life.
Mijn naam is Dante, ik ben 11 jaar. Ik woon in Schubertlaan 1. De dokter heeft de eerste keer gezegd dat ik aan muco leed als wij op reis waren. En dan, toen kreeg ik heel veel krampen en alles. En dan zijn wij teruggegaan en dan had de dokter dat gezegd dat ik muco had. Ik ben daar eigenlijk met mijn gedachten gewoon mee opgegroeid. Want ja, ik was nog heel klein toen als ze wisten pas. Mijn 2 favoriete dingen zijn op trampoline spelen en worstelen. De trampoline is leuk omdat ik ben met muco heb ik echt moeten beginnen sporten en zo. En dan, een trampoline is heel goed voor mij. Ik ben begonnen op zo'n kleintje. Van medicamenten, 's ochtends moet ik puffen. 's middags moet ik antibiotica nemen bij bommen. 's avonds neem ik ook antibiotica. En dan puff ik en moet ik aerosolen.
Dante, zet u maar. Oké.
Als ik bij mevrouw Linda ga, dan blaas ik met een longfunctie. Dat is zo in een klein dingetje. Zo hard mogelijk blazen voor te zien hoe goed dat die longen zijn.
En blaas, 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 blaas. Nog, blaas, 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 blaas.
Ik heb deurtjes in mijn longen zitten en mijn muco houdt die toe. Dat opnieuw blauwe pulletje. Dat zorgt er dan voor dat mijn deurtjes open gaan voor zout naar buiten te laten. In de zomer neem ik ook mijn worstelpopjes mee op de trampoline. En mijn honden komen daar ook soms op. Ik voel de trampoline als mijn domein eigenlijk zo. En daar speel ik eigenlijk elke dag op.
So Dante has a class 3 mutation, and you see the airway surface here again. And in class 3 mutations, the CFTR shown in yellow is made, it gets to the cell surface, but it doesn't transport chloride. It's a voltage-gated problem, so the chloride comes up and just can't get through that channel. Potentiators are drugs that lead to opening the channel, so that either Caftor or other potential drugs can open the channel, can improve airway surface liquid, and make that gunky green stuff turn into mucus that can be transported. Class 3 mutations, I said, are the ones where you make protein, it gets to the cell surface, but it's inactive. And by activating that, there's a potential for therapy. If you think about how CFTR works or how much chloride can be transported, it's a combination of the number of channels that are in the airway or in the airway cell, the open probability times the conductance. And in class 3 mutations, that open probability is diminished. So if you can increase this, you can increase the amount of chloride transport because there is CFTR at the cell surface. G551D is the typical mutation we talk about as a class 3 mutation. It's the most common class 3 mutation. But there is a significant variability between expression in different countries. This shows heterozygotes in the pale blue and homozygotes in the dark blue. And you can see there's a range of prevalence across the world. And this shows Europe, where Ireland has the highest prevalence. For other countries, such as Portugal, it's much less frequent. Patients with class 3 mutations have symptoms that are similar to what you heard about for class 1 and class 2. They tend to have high sweat chlorides over 100. This compares class 1 and class 2 to class 3 mutations. FEV1s that are similar, colonization with Pseudomonas that's similar, and tend to be pancreatic insufficient. It's now been 2 years, I guess, or a year and a half since this data was published in the New England Journal about ivacaftor. I just want to review it briefly because it does show a dramatic improvement and what led to the FDA and European approvals for this drug. This shows a change in FEV1, a placebo here in the gray compared to the blue, which is ivacaftor, where you see a dramatic increase in FEV1 that's maintained over 48 weeks. This is associated with a diminution in exacerbations, so that the people that took ivacaftor had fewer exacerbations at the end of 48 weeks compared to the placebo group. This also translated to an improvement in quality of life, where the placebo group was, or the ivacaftor group was substantially better than the placebo group, and an increase in weight, where patients gained weight substantially more on the drug than compared to the placebo. This medication also works for younger children with milder lung disease. This is a study of patients 6 to 11 years of age, showing again this improvement in lung function that occurred very early on in the first 2 weeks that was maintained over time compared to the placebo, which was unchanged. And a similar change in weight was seen where the placebo group is gaining weight here, because these are children that should be gaining weight as they get older, but the ivacaftor group continued to have a better weight gain than the placebo. The mechanism of ivacaftor has been elucidated over the past few years. This paper from PNAS demonstrates that what happens is that ivacaftor decouples the gating that occurs from the ATP hydrolysis cycle. So typically ATP is hydrolyzed. That allows chloride to move through the channel. In this case, decoupling that will stimulate not only defective CFTR, but also normal CFTR that's at the cell surface. This has the potential to treat other class 3 mutations beyond G551D, and perhaps, as you'll hear, class 4 and 5 mutations as well. This is cell culture looking at chloride transport. The white is unstimulated, or is a baseline, and the black is with ivacaftor. Here is a normal wild-type CFTR. When you stimulate that, there's an improvement in chloride transport with ivacaftor. You see that same improvement in G551D that has no transport at baseline, but substantial transport with ivacaftor. But other mutations that have poor transport at baseline can be effectively stimulated by ivacaftor. Because it's a pill, it acts not only in the lungs but other places, there's been a lot of discussion about sweat chloride as a biomarker for ivacaftor and other medications that can activate CFTR. This is the data that was published in the New England Journal showing the change in sweat chloride, placebo not changing at all, with a dramatic drop with ivacaftor. And in fact, with this drop, you see a drop below the diagnostic criteria for cystic fibrosis of 60 milliequivalents per liter, or millimoles per liter. And to get to the point where you'd say these people wouldn't have cystic fibrosis if you saw them de novo. However, that relationship, there hasn't been a clear relationship between that change in sweat chloride and a change in lung function. When you look at the group as a whole, or the groups as a whole that have been studied, you get a scatter. When you look at the absolute change in sweat chloride compared to the absolute change in baseline from the two large trials, you see there's really no clear correlation between the two. So the people with higher changes in sweat chloride didn't have a higher increase in lung function. However, a more recent study has shown that perhaps you can get some information about lung function change looking at sweat chloride earlier in the process, or earlier in the therapy. So instead of looking at the same time point, this study looked at the change in sweat chloride at 2 weeks, or day 15, and whether that could predict a change in lung function at week 16. So here, as the sweat chloride gets better, so this is improvement, lower, that group tends to have a higher lung function. So the same thing is shown here, just looking instead at the sweat chloride absolute number, but the change. So here, this is improved with a higher lung function. These authors feel or suggest that this could be used as a way of predicting the future of lung function change, at least for those people that actually have an improvement in sweat chloride. When they looked at changes in sweat chloride, either the decrease of more than 20, whether the concentration fell below 80, or a combination of the two, it had a reasonable positive predictive value. So if your sweat chloride improved, there was a high likelihood that your lung function improved. The opposite was not really true, though. The negative predictive value was not particularly good. So not having sweat chloride improve doesn't tell you that you're not going to have a lung function change. So there still may be benefit in lung function, even though the sweat chloride doesn't change. So in conclusion, I think that I've shown that ivacaftor is effective for individuals with a G551D CFTR mutation. It's probably effective in other gating mutations. We'll need to have clinical data to show that. And sweat chloride, which we've hoped would be a biomarker that can predict function or predict lung function changes, may in fact be something that can be used in this way, not only for treatment with ivacaftor, but other potentiators or correctors and molecules we'll be seeing in the future.